So ideally, you will have done this homework and made your attempt at filling in the blanks, and then you're watching or listening to this recording when you're checking your answers. Why? Because the act of actually looking the stuff up is what really benefits you and helps to bring all those ideas back to the kind of like let them bubble back to the surface. So you have that information fresh in your brain when you are taking this exam. Obviously, we went through the curriculum in IV therapy and the law, and you saw the expansive curriculum that the State Board of Nursing requires for IV therapy. And that's why I created this particular assignment, so you would have an opportunity to kind of let that stuff percolate back to the surface, so it would be a little bit more easy to recall. So the first area that I want to talk about is documentation. You need to review a little bit of your documentation notes, know the difference between source-oriented and problem-oriented medical records, know which ones focus on narrative charting and which focus on like SOAP notes. That would be a good thing to kind of know at this point. What is the threefold purpose of documentation? Well, it's to record pertinent information about the patient's status, and it's how we communicate with one another. Ultimately, documentation is a form of communication. It also creates a legal record of the care provided, and it helps us to obtain reimbursement. If we don't chart things, then it's assumed that we didn't do things, and then we are not going to be reimbursed. When the medical unit is not reimbursed for the things that it does, then it doesn't have enough money there to hire more nurses and pay nurses overtime and things like that. Abbreviations, guys, I made you learn abbreviations your first 7 weeks in the program, and those abbreviations will not be explained to you on the exam. Abbreviations that I've introduced along the way in this lecture series and in this unit, those are not going to be explained. When you see IVPB on an exam, you can't come up and ask me what that means. I'm not going to tell you, okay? You have to know what those abbreviations are. We never abbreviate drug names. Now, I know we say gent instead of gentamicin, and we all kind of know what we mean. But when you're writing out a drug order or you're writing something down, never abbreviate that drug name, because that's too important. There are too many drugs that sound too similar, and you don't want to take a chance on them being misinterpreted. Another big issue we talked about in documentation is an incident report. Incident reports should be initiated for any occurrence that is unusual. And remember, that can be certainly a patient occurrence, but it can also be something that happened that was untoward with, a family member or a visitor or even a fellow staff member. So incident reports are initiated for any type of unusual occurrence that happens. The report should be non-judgmental and factual, meaning just the facts. Stick to the objective stuff, not what you think happened. Only put in that report what you can observe. 3 events related to IV therapy that would necessitate initiation of an incident report. I still left these blank because there are a bajillion you could add in there. If you had a patient or visitor pass out while you were putting an IV in somebody else, that could be definitely an incident report. Obviously, if a nurse gets stuck in the process of putting in an IV, that's definitely going to be an incident report. And I'm sure that you can think of a lot of other, things. Bottom line is, if it's unusual, it involves a patient, a visitor, a family member, or an employee, you're going to have to write an incident report. What we don't ever do is mention the incident report in the patient's medical record. That incident report is prepared in order to limit liability in future situations. The minute you mention it in a patient's medical record, it becomes discoverable. And once it's discoverable, if the patient is suing the hospital, then the information in that incident report is no longer considered attorney-client work product. It is now considered a part of the medical record since it was mentioned. And therefore, the plaintiff's attorney can use the information collected in that incident report against you. So do not mention it in the patient's record. The next topic we will discuss is skin. You learned about the layers of the skin. You learned about skin way back in fundamentals, and then we did an entire unit on the skin in MedSearch 1. So you are well versed in this. The layers of the skin, you should have been able to answer that without even looking it up. It's the epidermis, which is the most superficial, then you've got the dermis, and then you've got the subcutaneous layers. The dermis is the layer that's highly vascular. The subcutaneous layer, although vessels run through it, subcutaneous is sub-Q fat. So while it is an avenue for vessels to run through, there aren't a lot of capillaries that are perfusing the subcutaneous tissue. So it is definitely not the best perfused, okay? The functions of the skin, well, let's see, it keeps the inside in. It is, it covers the entire body. It's the barrier, first line of defense. So that kind of goes along with protection. It provides protection and, somewhat obviously infection control, so infection protection as well as physical protection. Then you've got temperature regulation. Our skin helps us to, stay warm. It also helps us to cool off if necessary. And then, of course, it is, our method for getting sensation feedback. That touch feedback tells our brain what we're touching or what's touching us. Also tells our brain when a needle is being jammed into it and that, it doesn't feel so fantastic. So it covers the body, it provides protection, temperature regulation, and sensation. And then, like I said, the layer of the skin which contains the veins, the layer that we're going to be poking into with our needles, is the subcutaneous layer. Although it is fat, it's not well perfused, but that's where the veins run through. So next is the circulatory system. The circulatory system, of course, contains your arteries and veins, and the primary function of arteries is to carry oxygenated blood to tissues. Of course, it's carrying it away from the heart, arteries are, so that's oxygenated blood. The only exception to that fact in the adult is the pulmonary artery, which of course does not carry oxygenated blood. Then we have our veins, which return blood back to the heart. Veins use a system of valves and the muscle contractions around those veins to help return blood back to the heart so we have an adequate volume to push out again. Generally, veins themselves in the periphery really have no pressure in them unless we stick a tourniquet on the arm and we trap the blood. The only place we can really measure venous pressure is in the central venous system. That requires a catheter to measure that. I mean, you can get some idea if you look at jugular vein distension. If your patient's got JVD, then they probably have an increased central venous pressure. You have arteries that go to arterioles, which then go to capillaries, venules, and then veins. So that's kind of the way our process works. The three layers of the vessels are the tunica intima, the media, and the adventitia. The adventitia is that outer connective tissue. That's what, when you put the needle in and you kind of feel a pop, that's what you're going to be feeling right as you go through that adventitia. The intima is the smooth center that should give us unimpeded blood flow. And then the media is responsible for vasodilation and constriction related to, what's going on in the body. If you're cold, you're going to constrict. If you're warm, you vasodilate. So I mentioned this in the previous slide, but the vessels that contain valves are obviously your veins, and that's what assists to moving the blood back to the heart. So the valves are going to be part of that, tunica intima. The problem with valves is, as helpful as they are as to move blood back to the heart, they are a bugger when you're trying to start an IV. Because if you start an IV right where there's a valve, or you're trying to thread the cannula into the vein right where there is a valve, if your cannula gets caught on that valve, usually what it'll do is kind of tear a little hole in the side of the vein, and that quote unquote blows the vein. So valves are good for what they're good for, but when we're trying to start an IV, we are going to avoid those valves whenever possible. Can you see valves in everybody? No. Sometimes you can feel them better than you can see them, and sometimes you can't feel them at all. Sometimes it is just literally a crapshoot as to whether or not you're going to run into a valve. The two types of phlebitis are mechanical and chemical. We talked about this in class. Obviously, you do not want to start an IV in an area of flexion if you possibly can, because if it's in an area of flexion, every time the patient moves or flexes that area, the cannula is going to kind of scrape along kind of the bottom of the inside of that vein, and eventually it'll scrape until it just wears it away. It wears a hole in the vein, and then before you know it, you've got an infiltration. So your options are, if you must put it in an area of flexion, because that's maybe the only place you can find, you're going to need something to immobilize that IV site. So first of all, tape the site well so that the cannula doesn't just move around anyway. But then in addition to that, you might need an arm board or some kind of little reminder that the patient has so that they don't bend in that area. Chemical phlebitis is generally caused by either the chemical properties of whatever is being infused, like for instance, potassium chloride is just irritating chemically. There are other, medications, and I've mentioned that in one of our previous, lectures. But another thing is osmolarity. The higher the osmolarity content of whatever you are infusing, so the higher tonicity of whatever you're infusing, the more irritating it is to the tunica intima, okay? Also, think about it. If you're taking that high tonicity fluid and you are infusing it into a smaller vein, even if you try to put a good sized cannula in that smaller vein, it doesn't allow for a lot of flow around, meaning the blood flowing around the cannula isn't a lot. So what's coming out of the cannula, basically what you're infusing through the cannula, doesn't get to mix with a ton of blood. And so whatever it is, it's going to have some direct contact with the vein wall. That's what's going to give us that chemical phlebitis. Let's talk about a vasovagal response, because this is always a matter of some discussion and contention. A vasovagal response is the response when the 10th cranial nerve, your vagal nerve, is stimulated and it has an impact on your vessels. Okay, that's where it comes at vasovagal. Okay, it's an undesirable autonomic response which results in two things. Basically, 1 inch of vasoconstriction. So basically, right where you're trying to poke that vessel with that needle, right where you're trying to poke it, that vessel is going to clamp down. It's going to get like really, really skinny and be like, I'm going to be very, very quiet and not, move. I'm not going to pump up. I'm going to stay as tiny as I can because someone is trying to hurt me. Well, yeah, we are. We're trying to poke you, but the vein doesn't like that. So it's going to vasoconstrict in that 1 inch. But then, and it's because it perceives it's under attack and being injured. But the rest of the body is going to vasodilate. And by vasodilation, I don't mean, oh, good, make veins plump up. What it does is vasodilate to the point where the blood goes to the periphery, leading to hypotension, and it's not, brought back very well. So what ends up happening is your patient feels faint. Sometimes they do actually pass out, but they're going to feel faint and dizzy, and bottom line, you're not going to get that IV. I'm sorry. You might as well pull the needle out and give them a few minutes to recover, put another tourniquet on somewhere else, and try somewhere else. And then I would highly recommend that when you do try somewhere else, that you focus on getting, sorry guys, lots of recordings, losing my voice here. You focus on trying to get that needle right into the vein instead of kind of go in and like look around for a little bit. If you can put that needle directly into the vein right when you first stick it, that's your best shot of actually getting it in before they can vagal, okay? So a vasovagal response is 1 inch of vasoconstriction right at the site where you're trying to stick. That's why you can't get it in, because that vein will flatten out. But everywhere else, they vasodilate, they pass out, they become hypotensive, and clearly this makes the IV attempt highly challenging. So if you remember from the curriculum, we not only had to discuss the circulatory system, we had to talk about how the blood moves through the adult heart. So the anatomy of the heart, I said starting with the vena cava, provide the pathway. I know this means you have a lot of blanks, and hopefully you have filled those in. I'm going to stop talking for a minute so you can look down at your paper, look up at my recording, and make sure that you got all this right. So I'm going to give you about 15 seconds to do that. Okay, if that was not enough time, it's fine. Just pause the recording and make sure it's all there. But we start with the vena cava, we go right atrium. Remember which one is the tri and bicuspid valves. We talk about the pulmonary artery, it goes to the lungs, the veins, comes back, blah, 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 and bada boom, it goes out the aorta. That should have been a no-brainer, really. You probably could do that without even looking it up, but I just wanted to make sure that you had that pathway correct. So lastly, we're going to talk about what effect the IV therapy related issues listed below have on the vascular system. And my answers are not the only answers, okay? I just threw some stuff on here so to get you thinking. I'm actually hoping that you had different answers than what I have, and you can kind of add this to what you came up with also, okay? Electrolyte imbalances, we know that electrolyte imbalances can cause all kinds of issues related to the vascular system. So it can cause arrhythmias, it can cause ineffective pumping. That would be kind of like a potassium issue and or a calcium issue. Okay, fluid volume overload, you can definitely see the symptoms of CHF in your patient. And then remember, if CHF is bad enough and our kidneys aren't kicking in and voiding out any extra fluid, then we're also going to have the possibility of pulmonary edema. If that pulmonary edema goes really, so pulmonary edema is caused if it's severe, but if it goes like epically severe, that pulmonary edema can actually lead to a pleural effusion as well. Then you've got speed shock and septicemia, both of which cause hypotension, speed shock, and then if you go far enough, it'll be septic shock. Anytime we say shock, you should be thinking hypotension. Not necessarily the first sign, but definitely the primary sign of any kind of shock. And when we're talking about that type of hypotension, most of the time we're talking about vasodilation. There's a couple of exceptions, but most of the time with septic shock, anaphylactic shock, neurogenic shock, and then of course speed shock, we're talking about a situation of massive vasodilation. They vasodilate so much, the blood goes out to the periphery. It's not being brought back to the heart, so the blood in the periphery cools, and that's why you kind of get that cool, clammy look to them, and then their blood pressure is crap. The thrombus and embolus situation, obviously, anything can be an obstruction. We've talked about blood clots for, since the beginning of time in nursing school. But recently, we've added to those obstructions things like catheter emboli that could cause an obstruction. We've also added the possibility of air being an obstruction. So you've added kind of to that repertoire now that we've had this additional information. And then a vasovagal reaction. I've talked to you about that already. Something can cause this stimulation of the vagus nerve. If that vagus nerve is stimulated, it generally causes vasodilation. The only exception would be is if you're trying to start an IV, right where you're poking that needle, that's where they're going to vasoconstrict. So what basically happens is, say you go to start an IV on somebody, and instead of poking through the vein, you kind of scrape the needle along the vein a little bit. I know that sounds terrible. Relax. Crap happens, okay? So you don't actually puncture it. The needle just kind of scrapes along the tunica adventitia. Well, that tunica adventitia gets the message that, like, oh Lord, I'm under attack. So it sends out chemical mediators that basically says, holy crap, I'm under attack. In response to that, right where it felt the injury, it's going to clamp down. And you'll hear us say, oh, that person's clamping down. Clamping down means that vein is going to constrict right in that little tiny bit of real estate right there. The problem is you can't really, if you took a hose and you flattened it out completely and then you were trying to cannulate the hose, would it be very easy? I hope you said no. No, it wouldn't. We want that hose all puffed up and filled with fluid. That's when it's going to be easier to get the needle in. Well, the minute we have that vasovagal response, that 1 little inch of area that we're trying to stick in, it's going to clamp down. So getting that IV needle in is going to be damn near impossible, okay? But then the rest of the body vasodilates, and so, good luck even starting an IV somewhere else at that point. You usually have to give them a couple of minutes to recover before you even attempt it. All right, let's talk the respiratory system now. Obviously, the function of the respiratory system is the exchange of gases, oxygen and CO2. Of course, gas exchange happens at the alveolar level, okay? That's actual respiration. Then we have cellular respiration when we actually take the oxygen to the cells. Oxygen diffuses into the cells, CO2 diffuses out, and then life is grand because that CO2 then gets back in your bloodstream and you exhale it out the next time you exhale. The other primary function of the pulmonary system is to help manage acid-base balance. Remember that while the kidneys are the master chemists and they are very good and systematic at managing acid-base balance, since they're so precise, it's like they're almost like a little OCD, so they're slow. They're a lot of times reactionary and they're a little slow on the uptake. Whereas the lungs, they're not as precise at what they're doing. They're just like, all right, I need to do something, throw everything I got at it, but they're quick. So a lot of times the lungs will be quick to help try to compensate for an acid-base balance if in fact they're not the cause of it. So lungs, you get a very quick response, maybe not as precise. You might have some, issues to deal with on the other side of it. The kidneys are very precise, very systematic, but they're going to be slower. They're going to be so systematic that they take a little longer to do it. IV therapy related pulmonary changes, fluid volume excess. Remember that, what tends to happen when somebody is in fluid volume overload, or dare I say hypervolemia, they're going to shift fluid into any place that will kind of fit that fluid. One of the places that will do that is the lungs. So they shift the fluid into the lungs, and what that does is it puts an additional fluid barrier between oxygen and CO2 exchange, gas exchange. So it's harder for oxygen to diffuse into the patient from the air, and it's harder for the patient to diffuse the CO2 out and get rid of it since it's a waste product. What that can cause is it can cause changes in your ability to oxygenate. So it can cause a situation where you're in hypoxia or hypoxemia. It can also change your pH. It can affect your respiratory rate. It can affect, the quality of your respirations. So there's a lot that IV therapy can impact on the pulmonary system. And of course, like we mentioned before, there's all kinds of emboli that we have to worry about. And while emboli tend to form in the vascular system, and we usually think of it as a vascular problem, and it is, sometimes, a lot of times, emboli end up in the lungs. So what starts off as a circulatory issue very quickly turns into a respiratory issue that causes very sudden onset respiratory distress. And if you can't intervene quickly, or if it involves a large portion of the lungs, there may not be an intervention possible at that point that can save the patient. Certainly, I don't want you to think every patient who gets a PE dies. They do not. But a PE is a bad situation, and patients, there is a certain level of mortality associated with pulmonary emboli. So switching gears again, we're going to talk about hematology. Functions of blood. Okay, we can all agree blood has a lot of functions. But if I was just going to kind of put them in broad terms, some of the things I might come up with are that, one of the jobs of blood is to deliver nutrients out to the body. One of those nutrients happens to be oxygen. Okay, I think we can all agree on that one. And we just said, if you deliver nutrients out to the body, what do you then have to do? You have to pick up what? Wastes. So you're going to pick up those waste products and you're going to bring them back so that they can be discarded. So two primary functions would be deliver nutrients and pick up wastes. And then another way that the blood helps your body is by temperature regulation. Your blood will help to maintain your temperature. If you start getting really cold, you vasoconstrict so that your blood goes to the center of your body and keeps your core temperature warm. Okay? If you're hot, your vasculature vasodilates, the blood goes out to the periphery, and that blood is very warm. So what ends up happening is it allows heat to escape because some of that is going, out into the capillaries. So body temperature regulation. And then, of course, protection against infection. We have our white blood cells. We've got not only the granulocytes, the neutrophils, eosinophils, and basophils, but we've got our lymphocytes. We've got our monocytes, our macrophages. We have multiple ways to clean our body of any kind of infectious organism or virus or anything else. Of course, right now, viruses are on everyone's mind, but you have these protections built into your body. And the beauty is they adapt. Now, it may not be a fun process while they adapt, but they do adapt generally to whatever is, infecting them. Blood components. Well, you spent your entire hematology unit talking about the formed elements, right? You talked about, I think it's on the next slide, but you talked about red blood cells, white blood cells, platelets. You talked about diseases, red blood cell, like anemias. You talked about white blood cell problems. So we got a big dose of that. What we don't tend to concentrate on a lot is the plasma. And in IV therapy, plasma is kind of our jam because that's what we're trying to do. When we give IV fluids, one of the things that we're expanding is our plasma volume, right? I'm not increasing your number of red blood cells when I give you normal saline, but I'm increasing your overall blood volume because I'm expanding your plasma. Now, I'm not talking about honest to goodness plasma expanders like Hespan. I'm just talking about good old fashioned, normal saline. Plasma is made up of water, blood clotting factors, nutritive materials. That's where your fat, carbohydrates, and proteins get broken down into a soluble form. Yes, fat is water soluble when it's coated in those phospholipids. And then you've got your mineral salts, like all of your electrolytes that we spent beaucoup amount of time talking about. You've got your gases, you've got your waste products. And then remember, we haven't even thought about endocrine in a while, but you've got all those hormones, you've got your antibodies, you've got enzymes. All of that is going to be in your plasma. And here they are, your formed elements of your blood, your red blood cells, your white blood cells, your platelets. Remember that all of your formed elements come from stem cells. So you have stem cells in your bone marrow that can grow up to be reds, whites, or platelets. And it's usually some kind of trigger within the blood that tells the bone marrow what it is we need to create. So for instance, if you think back to the kidneys, if you are low on red blood cells, the kidney measures that slight drop in oxygenation and it releases what? I hope you said erythropoietin. Erythropoietin then goes to the bone marrow and says, hey, bone marrow, guess what? I know you've got these stem cells. Right now, I need you to make some grow up and be red blood cells. I need some. So the bone marrow then focuses on RBC production. Well, if you're in the middle of an infection or you're fighting an infection, then you might have chemical mediators that go to, like interferon and all those wonderful things that go to the bone marrow and say, hey, kind of having a hard time over here with this, foreign invader, so how about you make some white blood cells? And then same thing if our blood clotting factors or our platelets drop, we get all of those opportunities to, then potentially make platelets. Now, all of these are important in IV therapy because you need red blood cells for oxygenation, to oxygenate the tissues. You need white blood cells to fight the infection or any potential infectious agent that might have been given access by IV therapy, or because the IV is sitting in their arm for 3 or 4 days, that can be a portal of entry. And then of course thrombocytes, you need to clot. Eventually we're going to take that IV out, and when we do, we need them to have adequate ability to clot where that IV has been removed. So let's talk about blood clotting. Obviously you touched on this pretty much in depth in hematology, but the first thing that's going to happen is platelets are going to cling to the site of injury, and then serotonin will be released, causing some vasospasm. Thromboplastin then triggers the clotting cascade. And remember, not one, but two separate places in that clotting cascade, you need calcium. So when we pull an IV out of somebody's hand, arm, whatever, and we put that 2x2 over and we're holding it, don't hold it for 10 seconds and think that you're good, okay? I can't even say all of that in 10 seconds, let alone actually expect it to clot. Now, if you put an IV needle in somebody's arm and you didn't get the vein, you never ended up getting the vein, and you pull the needle out, chances are, yes, that sucker is going to clot off pretty quickly because, hey, we never accessed a vein. So all you've got to really worry about are the capillaries at the dermal level, the skin level, okay? It's not going to take very long for them to clot off. But if you actually cannulated a vein, whether the vein blew, it doesn't matter. If your needle successfully penetrated the vein wall, then you're going to have to hold that for a little while because you're going to have to wait for those platelets to get to the site of the inside of that vein. And basically, remember, it's got to build the clot from the inside. So when we're putting pressure, we're impeding the blood flow through that area, making it so that there's like a big speed bump in the road. So more and more platelets that are floating through the bloodstream will cling to that site of injury. So by holding good pressure, you're increasing the speed with which the cascade will happen, but you still have to be patient and let it happen. The one thing you are going to get in a world of hurt and trouble with is if you don't take the time to get adequate hemostasis when you pull an IV out of somebody. There is no excuse for pulling an IV out of somebody and then having that thing, bleed 5 minutes after you leave the room and the patient's calling because their dressing is soaked in blood. That's all you, because you didn't make sure that you got adequate hemostasis before you left. You've got to make sure that that thing has stopped bleeding before you leave the room. All right, let's concentrate on our white blood cells now. So we have granulocytes and agranulocytes. You've got your granulocytes, which are the neutrophils, basophils, and eosinophils. They're granulocytes because when you look at them, they look like they have granules in them. I mean, they're really not granules, but that's what they look like. Agranulocytes don't have that. Those are your lymphocytes, your monocytes, your macrophages. Monocytes tend to position themselves in tissue and wait for something to kind of come to them, whereas your macrophages are mobile. You've had some of the macrophages in your body for 5 years. Macrophages are like the Goodyear blimp. I mean, they are large, they use phagocytosis, they are able to envelop a bunch of cellular debris and garbage that's in your body, and they have enzymes within them that basically break down whatever it is that they envelop. And after, so much time, they've just done it for long enough that they don't do it anymore. I mean, think about that. Your red blood cells only work for 90 to 120 days, and they're done. Those macrophages work for years to help keep your blood clean of any invading or infecting organism. So when we're talking about ways to prevent infection as relating to IV therapy, you have to understand where the main sources of potential contamination are. And that is air, meaning if our IV materials that we're going to stick on the patient or stick into the patient, if they've been exposed to the air for a prolonged period of time, like I've said to you a million times, stand aside when a sunbeam is coming through your window and look at all the crap floating around in your air. So you have to think about the longer you have an IV needle exposed and outside of its cap, waiting to go into the patient, that's more and more time that one of those particles that are in the air can land on that cannula. Blood itself, when you put the cannula in, one of the reasons the cannula is on the outside of the needle is so that when the needle makes the hole in the skin, the cannula actually plugs that hole a little bigger. If you understand what I mean, since it's over the needle, it actually maybe even does a better job of filling that hole. so there's less chance that blood will seep back up from the vein up the cannula and come out around the hub. Now, it still happens sometimes. If blood gets up and around that hub and sits on the patient's skin, that is a big area, because what is that? It's wet, it's going to be warm, and let's face it, blood has all the goods that a bacteria needs to survive on. So that would be a way to contaminate. And then the skin itself, especially if we did not do a very good job of disinfecting the skin, prepping the skin before we put the IV in, or if we, pulled a total bonehead move and retouched the skin, because a lot of people think, oh, well, I have a glove on. That glove is sitting on the wall in the patient's room. There's nothing sterile about that glove. That glove is not even really totally clean. All that glove is doing is protecting us from direct contact with body fluids. You don't consider it clean, sterile, anything like that. You just consider it a barrier. Your hands are probably cleaner than the glove, since you would have just washed your hands before you did all of this. So stop thinking that the glove is good to go and you can retouch over where you've cleaned. That is not good practice. Sources of contamination can be intrinsic or extrinsic. Intrinsic means that they were present prior to use, meaning that needle was contaminated before you ever got it out of the package. Some other thing might have happened, whatever. Extrinsic is when it's introduced during therapy. So obviously, there are far more cases of extrinsic contamination than there ever would be of intrinsic. And if there is some type of intrinsic, they'll do a recall on fluids, or they'll do a recall on something because they've realized that, 2 or 3 things from the same lot number and, blah, blah, blah has happened. So that's when you'll see intrinsic stuff. Extrinsic is what we run into far more frequently. So what are some things that can contribute to an IV infection? Well, inadequate hand washing. The people who just put the tips of their fingers under the water and rub them together and call life good. We're nurses, we do better than that. With all this virus stuff going around, and I've seen it on Facebook and stuff, and it's true. It's kind of funny, but it is true. Hey, we were washing our hands before it was trendy, and we're good at it. We generally do a good job, so I don't see that as a big issue, especially on the nurses that are, trained by us. Faulty handling of equipment. Although you'll be taught how to handle it, sometimes you just kind of go into brain lock and you touch things you're not supposed to touch. You know what? As long as you recognize it and don't use it on the patient, it is what it is. You're going to contaminate, guys. I've told you that a million times. The only perfect nurses are the ones who don't practice. You can be perfect when you never actually touch anybody. Using outdated fluids. If you are not keeping track of the fluids that you're using, or even a container that's been opened for more than 24 hours, that's considered an outdated fluid. Those fluids only maintain bacteriostasis for so long, and then the possibility of bacterial invasion and multiplication goes up exponentially. So never use outdated fluids. Failing to clean injection ports. This is so bad. Nurses are so bad at this. And you know what? I'm going to get on my soapbox for a second. Warning, Michelle, stepping up. This is just pure lazy. This is just flat laziness at its finest. First of all, when you get to the clinical setting, put 3 or 4 alcohol swabs in your pocket. Don't put 30, put 3 or 4. Then you will have an alcohol swab in your pocket if you need one. You can always replenish throughout the day if you need it. But I always put 3 or 4 alcohol swabs in my pocket so I have it. That's just a good rule of thumb. This is so bad. Nurses are so bad at this. That is why they came up with the green caps. If you have not watched the green cap video on the Canvas, you need to watch that. But you'll see what? They literally put a barrier over those things that basically cleans the damn port when the nurse takes the cap off, which means nurses have been pretty poor at cleaning injection ports. Well, I hope that mine aren't, because honestly, if I haven't made you realize how important that is when that thing is laying in the bed with the patient and then nurses just access the dang thing, makes me nuts. The other thing you'll see is a nurse disconnects an IV line, say it was a secondary. They disconnect a secondary from a primary. They failed to bring a cap, So they just clip it onto that most distal injection port. And we'll talk about this in lab. Guys, if these slobs did not have a end cap or prepare so that they had an end cap in their pocket, what's the chance they had an alcohol swab and actually cleaned that port? So in my mind, they contaminated that, and I will never use tubing that is folded over on itself and where they use their own latex injection port as a stopper. Guys, it's not good practice, and I guarantee you that was likely contaminated. Another one is skimming the cannula across the skin. Sometimes skin's hard, and you guys will like skim the cannula, kind of like skipping a rock. You know what? It happens. Some people's skin are a little bit harder to get through than others. If it happens, just abort the mission. Just stop, discard that cannula, and get another one. And yes, you will probably have a couple of little, dots of blood on their skin where you hit the cannula. You know what? That is not tragic. You're talking about a tiny little capillary. It will clot up very quickly. Students like to beat themselves up over that. Guys, there's things to beat yourself up on. That's not one. It's just not. You are not going to be good at this until you've done it for a while. But as long as you don't make mistakes that introduce infection, you're good. You're fine. You will get better. Cut yourself a little slack and understand that you are not going to be perfect day one. Okay, so we were not going to get through infection control without talking about the bloodborne pathogen standard, all right? You got to know it. Universal precautions is okay, but it excludes some important fluids. Plus, it doesn't take, really, universal precautions is all about bloodborne pathogens only. We know that while that is a standard that we want to follow, bloodborne pathogens are not the only pathogens that we have to protect ourselves from. So what do we use on a daily basis? We use standard precautions. Standard precautions still protects us from bloodborne pathogens, but it protects us from a myriad of other things that we run into. And it's all kind of based on that premise of if it's wet and it's not yours, do not touch it without gloves, okay? If anything that you're about to do, there is a risk that you are about to get wet, then put on the proper PPE. You've got to think past 2 minutes from now, and you have to have a little bit of imagination and think, well, let's see, if this would happen, that could happen, I might need a gown for this, or I might need a splash mask on my face for that. Regulated waste is another way of saying biohazard waste. Make sure that regulated waste goes into a biohazard bag, which is a red bag that has that biohazard symbol, which I'm sure you remember what it looks like. And then keep in mind what's what here. We have the CDC and OSHA. And with all of this coronavirus fantasticness, I mean, everybody's hearing about the CDC. You're probably getting the idea that the CDC makes rules. No. If you get on the CDC website and you look at things, the CDC is the Centers for Disease Control. That's one of your abbreviations, by the way. Is an administrative agency that provides guidelines. So the fact that they want social distancing right now and they don't want more than 50 people in a room or in a gathering, that's a guideline. Now, are there other guidelines that have come out from other agencies making that even more stringent? Yes. The CDC just put out their guidelines. Other places are free to make them more stringent, but these are guidelines based on the fact that CDC is an expert in their field. So you would be remiss to not at least follow their guidelines. You can make them more stringent, but you've at least got to follow the CDC's. Now, OSHA is an administrative agency that makes rules. Okay, there's the difference. CDC provides guidelines and really has no real teeth to enforce it. But OSHA, the Occupation Safety and Health Administration, not only makes rules for workplace safety, but they have the chops to enforce the rules. Meaning, if you don't abide by their rules and you're an employer, they can fine you, they can shut you down. You can have a lot of, they can take away your ability to even do business. So OSHA is an administrative agency that does have the ability to enforce. They make rules, so they have that legislative ability. They enforce rules, so they have the executive ability. And if you screw up, they decide what your punishment will be. So there's the judicial ability. So it's an administrative agency that really has all of those functions. And if you want to have a place of employment in the United States of America, you have to follow the rules put in place by OSHA. OSHA will take a lot of their guidelines from the CDC if it has to do with infection control, but OSHA is the one that's going to make the rules and enforce them. So hopefully you see the difference between those two. And then chain of infection. We should know the chain of infection. If you don't, quick overview is we have to start with what? What do we start with? And I'm sure I just heard you say pathogen. I'm sure of it. So yes, we start with a pathogen. That pathogen then has to have a reservoir for it to kind of percolate and multiply. So that's fantastic to think about. So we have a pathogen that is going to have a reservoir. Then it has to find a way out of that reservoir. So there's got to be a portal of exit. Once it's out of the reservoir, it has to have a mode of transmission to get to another person. So, and of course, as nurses, we never want to be that mode of transmission. So we started with a pathogen, we had a reservoir, we had a portal of exit, a mode of transmission, and now we have a portal of entry into a final step, susceptible host. So hand washing is going to stop this at pretty much every link in the chain can be broken with good hand washing. But other things that we want to do is we want to isolate those reservoirs. We're all up in the business of coronavirus right now, so we're talking about social distancing. That's a fantastic 2020 saying that means what nurses have been saying a long time is basically isolate the reservoir. Okay? By keeping your distance from other people, you are isolating your reservoir. So even if something could get out of you, the likelihood is it could not get to another person. That's all that we're doing. It's basic infection control practice. Okay? So obviously isolate our reservoirs. And then the other thing is keep up our host resistance. So we want to do things that bolster the immune system. We want to make sure that people are eating healthy, even whatever the situation is. It doesn't have to be 7-course meals, but healthy foods. So make sure they get a little color in their diet and they get good vitamins and minerals. That's going to go a long way to boosting your immune system. All right, so IV therapy across the lifespan involves basically talking about peds and gerons, right? Because pretty much all that we've talked about for the most part is adults. You know that the very young and the very old are always at most risk for what? For like everything. Just about everything that we talked about. The very old, the very young. Young because their systems are not as well developed. The very old because their systems are in a state of decline. Plus, older people have more chronic illnesses. They have other, it's kind of like a mixed bag of other issues that they may be experiencing at that time. For pediatrics, make sure that you make all of your explanations age appropriate. Don't talk about a cannula to a 4-year-old. Talk about a straw. There'll be a little tiny straw in your arm. Perform procedures in designated areas. Remember, in kiddos, we do not perform procedures in their room. We do not come at them in their bed. We take them to the treatment room, and the reason we do that is because we need them to have a safe space, and their safe space is their bed. Know your cannula sizes for peds. I'm pretty sure I told you guys in a previous lecture that if you had to guess, if you could only choose one and you had to guess, what number should you choose? Very good. I know I heard you say a 22. Fantastic. So 22 is our go-to size for pediatrics, okay? As you can tell, I'm trying to entertain myself while I talk to myself in my office since I don't get to see your smiling faces. Geriatrics. Geriatrics, you've got tons of chronic illnesses, but on top of that, gang, you usually have at least some bits of renal and or cardiovascular system impairment. okay? We're talking about IV therapy here. So we're talking essentially about plumbing. And the renal system and the cardiovascular system, they're plumbing. So when you have those gerunds who've got renal and cardiovascular issues, and then we add IV therapy to it, this is going to get more involved. There's going to be a lot more critical thinking that's going to have to be applied when you're thinking about how to handle things with a geriatric patient. Also, starting their IV is actually more challenging. Their skin is thinner, and while I fuss about sometimes the people with thick skin and it's really difficult to get the needle through, the problem with thin skin is when the skin is thinner and subcu tissue and all of that is thinner, those veins have abilities to roll and move. Well, gang, it is always harder to hit a moving target than it is a stationary target. And while that vein looks nice and big and juicy, the problem is when you go to try to hit it, a lot of times it will roll or scoot, and in the process of scooting, instead of poking the vein, you end up slicing the vein. And then you had this wonderful juicy vein that now has this long slice in it, and it's blown and you can't use it. And then of course, since the vein blew, you're going to have the potential for a hematoma, so you're going to have to hold pressure, and then you're going to have some pretty good bruising, so you're going to have yourself some ecchymosis in that area. Your best bet is to hold really good traction while you're inserting the cannula in a gerund. And the thing is, never hold traction in front of the needle, meaning do not put your hand above the site. The only place that it is appropriate to hold traction while you're starting an IV is below the site, because you do not want your hand in the pathway of that sharp object. Also, if their veins look really, visible and they're kind of puffed up, don't put a tight tourniquet on them. Put a very light tourniquet. I'm always trying to get you to tie tighter tourniquets because in most of you need a good tight one to plump the veins up. But on a gerund like that, you honestly need to have a very light tourniquet application. That'll help. Not only will it make the IV insertion a little easier and less likely to blow the vein, but it's less likely to cause ecchymosis or bruising if it would blow, or less likely to cause leaking later. So light tourniquet application is something that you would do for gerunds. All right, other things that we have to worry about with geriatrics are the increased risk of drug toxicities or interactions. Most of these guys come to us and they have a list of medications that is as long as your arm, or they come to you and they bring you the Walmart sack of medications that they're taking at home. There are multiple opportunities for there to be interactions between different drugs, and so we've got to do some research and look for those possible interactions. Their immune system becomes hypo-responsive to antigens, so one of the things that'll happen is an infectious agent will get into a gerund, and instead of getting that immediate response that lets us know, uh-oh, we have an infection brewing here, you are going to get a delayed response. So by the time the infection actually starts showing itself, they might be pretty far along in the process. That makes it harder to treat the infection and makes it more possible for that gerund to actually go into septicemia, because they probably had that infection brewing for a while and there just were no symptoms. You didn't do anything wrong. It's not like, oh, well, you didn't notice the symptoms. They will sometimes just not have any until such time as things start to go sideways. Many times they'll have decreased protein intake because their nutrition isn't fantastic. I mean, given what they want to eat on their tray, most of them like skip all the food and they just want to go to pie. I start thinking that pie becomes a food group when you're a gerund. Because I think some of it is just, as their taste ability, their taste buds decrease, the one taste that doesn't seem to lose its fervor is sugar. So they want to go to those sweets, and they really kind of stay away from a lot of the proteins. That's why we end up giving them drinks like Boost or Ensure or whatever, because we're trying to get protein in them in a form that they will actually, ingest. So we're going to expect for there to be diminished white blood cells, you're not going to make as many whites or reds, so your blanks are diminished white blood cells and red blood cells. And of course, if they're not taking in as much protein, then it's diminished albumin as well. Also, be careful with sensory deficits. Make sure your patient knows what you're going to do. Remember that in order to start an IV on a patient and not be charged with battery, which we're going to talk about the law stuff in a little bit, they have to know, they have to give consent. So you have to make sure that they do know what you're going to do and understand. And a lot of times if your patient is hard of hearing or they don't have their hearing aids or whatever, it's a little bit more difficult to communicate with them and just to shut you up. Sometimes they'll just be like, yeah, yeah, yeah. And then they're looking at you like a crazy person when you're coming at them with a needle. So make sure when you're talking to gerunds that they understand. Instead of asking for yes, no answers, say, can you repeat back to me what I'm going to do? And if they look at you like, what are you talking about? Okay, clearly they did not hear you, okay? Also, make sure when you're talking to them, lower your voice before you make it louder. So don't talk higher, talk lower and then louder. The lower tones are going to be heard a whole lot better. You can actually talk less loud. Is that a way to say it? Less loud if you speak in a lower tone. So sometimes you physically have to purposely lower the tone of your voice so that they can hear you.